We're excited today to welcome Dr. Ania Wajnberg for her grand rounds on cost and quality in high-risk patients in our health system. Dr. Wajnberg received her medical degree right here at Mount Sinai and subsequently went on to complete internal medicine residency in the primary care and social medicine track at Montefiore. After completing her residency, she returned to Mount Sinai, where she currently serves as clinical director for the Division of General Internal Medicine, as well as Senior Medical Director of Population Health within Mount Sinai Health Partners. Dr. Wajnberg's research focus is in health services, specifically evaluating models of care for high utilizers of the health system. Through her many years' experience with home-based primary and palliative care, Dr. Wajnberg has participated in building numerous innovative programs here at Mount Sinai. In addition to this, she has authored many publications and speaks nationally on the topics of home-based primary, palliative, and acute care, as well as on other team-based approaches to high-risk patients. Please join me in giving a warm welcome to Dr. Ania Wajnberg.
Hi, everyone. Thank you so much for being here. So I've been at Sinai for 15 years, and this is my first grand rounds, and naturally I woke up this morning with laryngitis. So I've had like 80 cups of tea, and I have more here. No one has ever told me that they couldn't hear me before, but if my voice starts giving out and you can't hear me, let me know and I'll try to yell through it. All right, so let's get started here. I have no disclosures. There are no disclosures in the field of high-risk patients. Basically, there's no option for disclosure. All right. So let me just give a shout out to Dr. Anna Blum, who was in the Visiting Doctors program for a long time. All the photos that you're going to see today are her work in our program. And this is my case. For those of you, especially the residents that have rotated through Visiting Docs, this is pretty typical Visiting Docs patient. So this woman is an 82-year-old female with diabetes on insulin. Her GFR is about 10. She's not yet started dialysis, though she has a fistula placed. She's hypertensive, she's frail, and she was referred to Visiting Docs after a number of rounds on the hamster wheel of ER, hospital, rehab, ER, hospital, rehab, and finally got sent over to our program. All her admissions were for hyperglycemia, hypoglycemia, or falls. I kind of wish that I had pictures of their home. I think it would be illustrative of the type of issues that we see. The home, when I arrived, was so cluttered, I could barely fit through the hallway, especially with my big Visiting Docs backpack. There were roaches visible in the apartment. The patient lives with her husband. They have no children and no family, and are trying to take care of each other, but the husband has some cognitive impairment, and actually the first day that I went to meet her, he had just come home from the hospital himself after some kind of spinal operative procedure. They have a few hours of home care, a few days a week, and all these issues are not for lack of trying. There were medications everywhere in the apartment, and they are really trying to get to all their appointments and kind of better their situation. All right, so before I get back to them and tell you a little bit more about them, I'm going to introduce what we're going to go through in the next hour. First, I'm going to attempt to summarize the United States healthcare system in about like 3 slides, so hopefully that should go well. Then I'm going to talk you through how this whole area emerged and how these high-risk patients are defined, and introduce you to a number of models that exist around the country to try to improve care for these patients, and share with you the evidence for some of these models and sort of where the field is going. And in doing so, I hope I'll be able to illustrate a number of programs that we've built here at Sinai, and remind you about them or introduce you to them if you're not aware of them. Okay, so here's the US healthcare system in 3 slides part. So I'm sure you've all seen this. The black line is the United States, and really the point that I'm making here is that no matter where you fall on our current political spectrum, whether you think our country should be investing in better military technology or better social services, it's really hard to do anything when you're spending 18% of your GDP on healthcare. So there's a large national conversation, for those of you that are trying not to pay attention these days, on how we can bend this cost curve and improve the care in this country. This is the same thing in a different format. Everybody's scared of this, and it's received, obviously, a tremendous amount of political attention. All right, and then at the same time, as that conversation is going on, the way that we are getting paid is changing in an attempt to try to bend this cost curve and hopefully improve quality. So without getting too much into this, we are being paid less for the services that we actually provide, and we are increasingly being paid more for the outcomes that we are working towards or the quality of the care that we provide. And that's really led to this environment where there's been a lot of research and attention to what we can do nationally to, like I said, bend that curve and improve the value that we're getting as a country in healthcare. So there are a number of options of how to do this. I am going to spend the rest of this time only talking about high-risk patients, but I don't want you to think that that's the only answer to this problem. There are plenty of other things being discussed out there that I'm not going to focus on today. One thing that I'm sure you're all familiar with, either from your own co-pays or from the complaints of your patients, is that because this is all getting so expensive, many payers, including some government payers, are shifting costs towards consumers. So that's one answer. We pay more out of pocket and the plans pay less. Another area that's getting a lot of attention these days is the cost of pharmaceutical drugs and how that contributes to all of this and how those costs could be decreased. And then there's a whole body of literature and research about what's sometimes called high-value care or low-value care, which basically refers to kind of over-testing. So how can we try to change behavior so that we don't give everybody with a headache a head CT or everybody with low back pain an MRI, and how can we bend the cost curve by doing that? So high-risk patients are not the only answer here, but they are certainly a huge topic of conversation nationally now, and I'm happy to take questions on this other stuff, but I'm going to focus on that today. All right, so where'd this idea come from? So really it came from this, which I'm sure you guys have seen before. This is the idea of like the pyramid of our population. So we've got the population on the bottom, and we've got costs on the y-axis. And as you can see, a small percentage of our US population drive most of the costs of our system. This is the same thing in a different format. And when you're thinking about how you want to improve care and cut costs, the idea here, kind of obviously, is that it might be a lot easier to figure out who that 1%, 5%, 10% are. It's a lot fewer people. And if you can bend the cost curve for them, you have the chance to really make an impact, as opposed to targeting the huge group in blue and have a much smaller potential impact. And this is really where this whole field of high risk, high needs, high cost, there are a lot of names for them, patients was born out of. So I think it's important to just mention this briefly. When this started getting a lot of attention in the last 5+ years, there is some question as to who these patients are. Are they all people who had like a totally non-preventable, devastating event that there was nothing we could have done about it anyway? I don't know, a major surgery, a transplant, et cetera. That would be sort of one avenue to think about and pursue. But many health economists have looked at this, and to kind of summarize the data, I would say about 15% of those costs, a little bit more than that in Medicare specifically, closer to 20%, are considered to be preventable. And what's driving that? Well, for those of us in medicine, this is not a surprise. These are the things that drive all of our work. Heart failure, pneumonia, UTIs, COPD, diabetes, dehydration. These are the top diagnoses where there's some potential to try to bend the cost and improve care for our patients. Like I said, this has gotten a tremendous amount of attention. I'm sure many of you saw this Atul Gawande article that launched tons of conferences, discussions, and kind of national research. He profiled a Camden program called a hotspotting program that looked for these high cost and high risk patients and then targeted them. And at this point, this is really out there, even not only in the lay press, but also in the medical literature. I cut out this New England Journal kind of call to arms from 2 years ago. So I'm sure at least some of you have seen this work before. Okay, I have to stop for 1 second and give a major caveat here. I don't know which one of these is me. Maybe the bun. But anyway, I am approaching this topic here from the perspective of really primary care and geriatrics, which are my departments. There is so much going on in this area at this institution alone, let alone nationally. And we would not be able to do any of the work we're doing without our specialty colleagues, surgical colleagues, inpatient colleagues. So I don't want you to think that this is a realm only in primary care, or that primary care could do this alone, or that the lists I'm about to go through are comprehensive, because they're not. There's, like I said, tons of work even just here being done in the Respiratory Institute and heart failure and hospital medicine and the Transplant Institute. I am not going to give grand rounds on all of those things. You're going to have to invite them to talk about their own programs, but I want to make sure that that was clear and I didn't give any false impression that this is, only a primary care issue. All right, so let's start with who are these patients? How do we find them? How are they defined? This picture kind of, sometimes when I talk about this, I feel like it's kind of funny, especially for clinicians. And this picture just highlights how sometimes I feel like these high-risk patients belong to another area where they say, you know it when you see it. So this is kind of like that. But when you look at the literature and you try to figure out, well, who are these patients nationally, there is no clear definition. Many societies define these patients by cost. So you look at claims and you kind of slice the expensive patients, and that's how they're defined. But many clinical groups look at patients that are relevant to them. So in the ED literature, there's a whole body of work about frequent flyers, patients who are bouncing in and out of the ER. In the inpatient medicine world, there's a term called super users, which are patients who are admitted frequently. In chronic disease, there's a whole body of literature about complex care, which really means you have out-of-control chronic disease or multiple chronic diseases that interact with one another. Many of these patients have been studied are in the last 6 or 12 months of life, and then there's a huge overlay here of behavioral health. So there's not kind of a one accepted definition, but all of these, the flavor is sort of similar, that these patients all have chronic illness and high medical and psychosocial needs. And so born out of this, models have emerged around the country to target these patients. And I'm going to talk about specific models in a minute, but all of them really have two underlying similarities that drive their work. The first one is you have to have a way to stratify patients. You don't need to apply, a super intensive model for a very low risk patient. You need to be able to know who needs kind of one pathway of care and who needs a different one, which traditionally is not really how we've structured our practices and requires some data support. And the second theme is that refers to that preventable slide that I showed you. The idea here is that you are going to bend the cost curve by decreasing inpatient costs and shifting them to the outpatient setting. All right, so what did we do here at Sinai when we started working on this? So again, this is about 5 years ago. And we thought it would be easy then, and we've learned that it's not so easy. And I'm going to take you through that a little bit. So when we started looking at this here, we entered a number of contracts with payers, and we started by looking at the patients who were incurring a lot of cost in those payers and thought we'd figure out who they were and tailor programs to their needs. A couple of things that we have learned that made this a little complicated. The first is data. So any of you that have tried to do clinical work driven by data won't be that surprised about this, but data is never perfect. It's very hard to capture true clinical reality. And when you use claims specifically, you're kind of running about 6 months or more behind, and it's very hard to intervene on patient issues 6 months later. A lot can change in that time frame. So this was really challenging for us to figure out who the high-risk patients were. Another thing that wasn't totally apparent to us at first and now has been described or starting to be described in the literature is we thought we could just slice patients, target them with our programs, and that would be it. Well, when you look at this over time and you apply whatever relevant algorithm you have to identify these patients, whether it's super users or high-cost patients, and you look a year later, only about 1/3 of them still meet your high-risk, high-needs criteria. So what that means is that risk is not like a one-time thing. It's something that changes for people over time. And I think that won't be that surprising to you as clinicians. You can think about somebody, for example, who had a stroke and incurs a ton of cost and now has a completely new baseline. But a year later, things have stabilized and they're in a new situation and they're not sort of in that acute phase anymore. And then finally, again, another thing that I think won't be that surprising for all of you, these high-risk patients are not one group clinically of patients. A 35-year-old substance abuser who's admitted for complications of their substance abuse is completely different, needs completely different things than an 85-year-old, like my example, visiting docs patient. So there's a lot of heterogeneity in this population and doesn't lend itself well to kind of one-size-fits-all intervention. So what does the literature show clinically drives this high risk or high cost label? Okay, so these are like the top 2 things. Not super surprising, but put them on their own slide so that you remember them. Fewer chronic conditions, lower cost. More chronic conditions, higher cost. Not rocket science. And the other one, which is huge, is frailty. That's probably the biggest predictor. And honestly, is not always easy for us to pull out of our claims data or even our EMR. We don't document this very well, so it's often hard for us to identify this, but it's a huge, huge predictor of poor outcomes and high cost. Other predictors, having Medicaid or poverty, low socioeconomic status, older age, and lower self-reported health status, which is a validated measure where you ask people what they think their own health is, and if they say poor or fair, they're much more likely to have worse outcomes and high costs than if they say good or excellent, which basically means that they know that they're not doing well. So does my patient fit this category? Well, I think almost in every way, the answer is yes, though I never asked her to self-report her health status, but she has older age, she's dually eligible, so has Medicare and Medicaid, definitely living in poverty, multiple chronic diseases, very frail. So I think no matter how you slice it, she's falling into this high-risk category. Now, Grand Rounds is not an easy place to be interactive and ask questions, but if it were, I would ask you guys what you think this patient needs. Does she need a better doctor to fix her problems? Does she need me to change her medication regimen or adjust even really her medication regimen? I think I picked this case because what we have found time and time again in our reviews of high-risk patients, and this is in the literature as well, is that what they need is really not what we consider traditionally medical. And again, I'm sure that all of you have seen this. I mean, it's been well described and well published that 60% of health outcomes are not driven by what we consider medical. I'm lumping genetics into the medical here. And really relate to social determinants, behavioral issues, issues of support, and things that, honestly, as doctors, we probably don't really know how to do that well. And it's out of this kind of realization and proof that many of these models emerged They all fall under this buzzword that you hear all the time now called care management. How do you manage these patients? Care manage these patients means a lot of different things. And in the next few minutes, I'm going to take you through some examples of these models, evidence behind them, and also take you through what we've built in primary care and geriatrics here at Sinai for different categories of these patients. Okay, so let's start with primary care in general. So there's been a lot of movement in primary care as a whole to evolve our model to be more team-based and interdisciplinary to tackle some of these issues for our patients with chronic disease. A few examples, and there are hundreds of examples. I could never go through all of them, so I tried to pick out ones that are illustrative of kind of concepts of this, or ones that have some decent data behind them. Medicare specifically has been very interested in this, and they did a randomized control trial where they picked certain sites and compared them to other sites and put RN care managers into primary care practices. And the idea is that the nurses would reach out to patients with different chronic diseases and kind of do health education and chronic disease management with them. And you can see here their results in the randomized control trial, about 10 to 15% reduction in inpatient utilization and cost. A different but kind of equally important and illustrative example is integrating behavioral health into primary care. So we know that many of our patients have behavioral health needs, that there aren't enough psychiatrists in the world that could meet their needs. And many of them won't go, even if they need to go. So there's been a whole body of literature about how to bring primary care together with behavioral health treatment. And in studies that have looked at that, they've also found roughly 10 to 15% cost decreases relatively quickly. And remember, this isn't a primary cost decrease due to the mental health issue. It's the improvement in the medical costs related to the treatment of the behavioral health issue. So what are we doing here at Sinai in primary care? So just like trying to jam the US healthcare system into 3 slides, I really can't summarize everything that's happening here in primary care in 1 slide, but I try to put a few concepts up here. We have dozens and dozens of primary care practices in our Sinai health system, and they're all a little different. But there's a huge move towards building a team-based approach across the system and trying to tailor the type of team-based approach to the needs of the population local to that primary care clinic. IMA doesn't necessarily need the exact same type of support as like our Williamsburg practice, but the idea is still to enhance the care that we're providing in a team-based model. There's a tremendous amount of work going into open access for our patients so that we can meet the needs of their chronic illnesses and to improving continuity. And all of our primary care practices are beginning now to work with data to understand who their high-risk patients are and how we can target them in a more intelligent manner. We have care management rolling out across all of our primary care systems, sometimes inside the practice, sometimes remote to the practice, mostly using nurses and social workers. And some of our practices, including here at this campus, we've been lucky enough to follow the model that I highlighted and integrate behavioral health into our practices so that we could try to touch as many of our patients who need it in as seamless of a way as possible. Many of our practices receive pharmacy support, CDEs, community health workers, and other examples of how we can enhance our medical practice, sort of, again, outside a little bit what we have traditionally considered the medical purview. Okay. The next bucket of targeting these patients is something that, again, has a couple different names in the literature. One of them is the ambulatory ICU model. It was developed about 10 years ago by Arnie Milstein at Stanford. And the idea, kind of like the medical inpatient ICU, is that you're taking care of a select small subgroup of patients, wrapping them in a team that is trying to case manage kind of everything about them. Many of these models, including the ones highlighted here, have one doctor who follows the patient, whether they're inpatient, outpatient, in a rehab, or any other kind of setting, knows them across the board, and works closely with a team. Some of them have been able to be even more innovative and pay for transportation directly or housing directly or anything else that the patient might need. One of the challenges in terms of data in this area is that a lot of the places that have done this, they are doing it either as part of an insurance company or as kind of a product that they want to sell to other health systems. They tend to be not super academic, so they're not sharing. These are all proprietary models, and it's hard to kind of get robust data about them, but one very famous one called CareMore, they openly do share that they've been able to cut costs compared to regional averages, and that's been enough for them to sustain their model. One academic site that I did find that has been working on this is in Oregon Health Sciences, and they also did a randomized controlled trial between primary care sites. So they put these intensive ambulatory ICUs in a few of their sites and not in other sites. And they did find a decrease in hospitalizations. They haven't reported on costs. They may not be able to report on that. And they, interestingly, especially in diabetes, also found improvements in mortality in this model. So we're lucky at Sinai to have been able to build the first of these types of ambulatory ICUs. It's here at IMA. It's called Peak Health. We use a combination of data, so payer data, and referrals to take in patients. We see these patients very frequently, usually more than even once a month. And we have open access, so they can come on the same day as they need us. What do they get that's a little different than primary care? Well, they get a provider who has a much smaller panel and kind of more time to spend with them. They all get a social worker and a care coordinator who see them. They get a gigantic comprehensive assessment that is meant to figure out what's driving their poor outcomes, and it includes a whole host of psychosocial things as well as medical. So we've tried to spend our time with them working towards the goals that they have identified and that we identified to improve their care. Since I showed you that risk is not static, the patients often move in and out of this. So they don't need us necessarily forever. Once they're stabilized, they can move back to wherever their primary care site was. We have much more flexibility than traditional primary care setting. We very closely involve family and caregivers in their care, and we do have the ability to see them at home or meet them in the community, visit them in the hospital, etc. Okay, so now I'm going to talk a little bit about home-based primary care. As many of you know, Sinai has one of, if not the biggest, academic house calls programs in the country. We've been around for over 25 years. We have a lot of experience in this area. You may know, or maybe not, that as part of the Affordable Care Act, Medicare launched a shared savings demonstration project specific to house calls, so outside of the ACOs. It's called Independence at Home, and they selected about 15 to 20 house calls programs around the country to be in like a special shared savings demonstration program. And in that program, in the first 2 years, they did find reductions in admissions and readmissions. They saved over $1,000 per person per year in these models. There was variability between programs. So all these programs are a little bit different, and some didn't meet the threshold to shared savings. I can't say that all 15 did, but the ones that did received pretty significant amounts of money, especially considering that these programs tend to be pretty small and not, targeting huge numbers of patients. So there's a lot of interest in this right now on a national level. So I'm going to talk just for a minute about visiting docs and also show you this woman's amazing kitchen decorating. I think it's my favorite, one of my favorite kitchens ever. All right, so many of the residents have come out with us. Maybe some of you, you're always welcome to come out with us. We provide primary and palliative care for our patients in the home. We work very closely on teams. This work is impossible without a team. We have doctors available for these patients 24/7. We make urgent visits as well as routine visits. When you go into the home, you kind of can't help it. We work very closely with the families and caregivers of these patients, and we also work closely with community agencies and nursing agencies to try to extend our reach. We're proud to be able to facilitate dying at home for patients who choose that outcome. And in our own internal published work, we've shown that for our highest risk patients, we've been able to cut their hospitalizations in half after they are enrolled in our program. All right. I'm going to talk for a minute now about our hospitalization at home program, which was really born out of our experience, I think, and our comfort in providing care in the home. So this is not a new model, though I'm proud to say that now at Sinai we have some of the greatest experience in our country with it. I'm going to share that with you in a minute. But the idea for this was really born out of Dr. Leff at Johns Hopkins about 20 years ago. And there have been many, many, many studies. Actually, this model is not uncommon internationally. And so a lot of data has come from, for example, Australia, where they do this routinely as part of their national health system. But there's more limited data in the United States, and especially in a market like, fragmented market like New York City. So all these studies, even before our Sinai program, have showed reduced complications of hospitalization. So less delirium, less falls, less wounds, less line infections, that sort of thing. Good patient satisfaction, and savings when compared to matched patients for similar diagnoses in the hospital setting. The program here started with a large award from CMS to bring this again to kind of the New York City fee-for-service market. And we take patients from the emergency department and send them home and provide their acute level of care in the home. And then we provide a kind of 30-day follow-up time period to try to ensure that they're stable before we discharge them. While they are admitted, they get daily visits from a provider. They usually get multiple visits a day from a nurse. We can do video visits with them as needed. They all get a social work assessment and a PT assessment, similar to the hospital. And we work closely with paramedics in the community who can assess patients if urgent needs arrive very quickly and communicate with us about what's going on. So led by Dr. Fetterman, who I see here, we recently published, I think, the first paper of our outcomes, with more soon to come, I'm sure. And you can see here that in our study of our work, we found a reduction in length of stay, reductions in readmissions, ER visits, and skilled nursing facilities, not that surprisingly. Hopefully you're not going home. I mean, you're not going to a skilled nursing facility from home. We also found in this paper good patient satisfaction. This was acceptable to patients, and most of them were quite happy to be in their home environment instead of in the hospital. Okay, this is the last bucket I'm going to go through. So this falls a little bit slightly outside the purview of primary care, which I promised I was going to stick to, but you really can't talk about high-risk patients and not mention transitions. As I'm sure all of you know, hospital readmission penalties have been around for some time now, and there's been a lot of incentive to try to keep patients out once they are admitted to us. And so some of this work that has focused on that peri-hospitalization period is actually the best studied of all of this. And I highlighted here two pretty famous, well-known models, the Coleman model and the Naylor model. I'm sure a lot of you have heard of them. They've been around for some time, and they are somewhat similar. The Coleman model uses NPs and a team to kind of activate the patient and try to get them taking better care of their own condition so that they don't come back. And the Naylor model is a bit more like hold your hand and take care of you so that you don't come back, but they're pretty similar. And both of them in randomized controlled trials found about a third reduction in readmission and the related cost reduction. Now, that being said, these transitional 30-day programs, probably not surprisingly, the costs tend to come back. So these are not cost reductions that stay sustained forever and ever. By 6 months, usually, the costs have returned to where they were in the beginning. And again, I couldn't possibly summarize all this work. There's tons of work going on here in every service line in our hospitals to try to improve this. There have been huge efforts to improve our discharge process that I'm sure many of you see every day, and education for patients around that, to provide medications to our patients before they leave, to care manage these patients in this high-risk time. We have a whole call center of nurses that are calling patients after discharge to make sure they filled their medications and are going to see their PCP. On the outpatient side, we've built access to allow these patients to come to us right away. When this became sort of a big focus in the hospital, they would ask us to see patients within 2 weeks. Then it got shortened to 1 week. Now we're at 48 hours. So we really need almost completely open access to get these patients in when they need us. Okay. So what do we do with all of this? So I think I've highlighted some of the challenges here. There's not like one gold standard. You can't just say, well, I'm going to target these high-risk patients, immediately know who they should be and exactly what program will work for them. In the studies that I listed here, there's tremendous variability in the groups targeted and both their clinical and demographic kind of characteristics. Another big challenge is that the programs are very different. Even though the flavors are similar, you know, should you be using a nurse? Do you need a social worker? Do you need a pharmacist? Do you need to be doing house calls? Can you do this in the office? There's no clear answers for exactly what these programs, you know, should look like. The methods in a lot of this work are not the most robust from a research perspective. I tried to kind of pull out where there were pockets of randomized controlled trials here, but a lot of this stuff that gets discussed is pre-post. I mean, even that whole Atul Gawande article is really about, you know, before enrollment and after enrollment, which we all know is not perfect. I mentioned that many of the models that are doing this most successfully from a financial point of view are proprietary. And so we can't even really figure out what algorithms they're using or what their models exactly look like. And I think it's also important to note that this is pretty resource intensive. This is not like, you know, change the behavior of your doctors and you'll get this outcome. I mean, this involves hiring people, creating new structures, creating new infrastructure. So the cost benefit not only has to be improved for the patient, but it also has to make up for the resources that you're investing in this in order to be a sustainable program. But that being said, for those of us who love working with these patients, and I think many of us go into medicine because we want to work with these chronically ill and vulnerable patients, this is a tremendously exciting time where you can really innovate and think about what it is that you believe would help your patients and what kind of team you would need to impact your practice and make the care better for your patients. And I think that that's exciting, and I would encourage all of you to think about that as the finances and kind of national interest have created an environment where some of this stuff really is feasible. I also mentioned we were here for Grand Rounds recently where we learned about burnout and physician wellness, and I think there are hopes that if we can do this better and make our care better for our patients and our own practice better, that there may be impacts on wellness as well. Okay, so let's get back to my patient here. So what did we do for this patient? So I actually see my social worker here. This bullet, getting home care, seems like it's no big deal, but it like requires 1 million hours of work and bank visits and, you know, court visits and God knows whatever else. It's not a small feat, but I think that's probably the biggest. When I first met this couple, they really didn't even have food in their house, so at least now some of the more basic needs are being cared for. The home was deep cleaned and exterminated and decluttered, which again sounds like no big deal, but this can be very invasive for patients and embarrassing and traumatizing, so it takes a lot of legwork to kind of convince them that this needs to get done. Maybe my tiny piece of all of this, I basically love stopping everybody's meds. It's like my favorite intervention, so I did a lot of that here. I think when I met this woman, she was on 24 units of insulin, and now she's on 8 units of insulin. You know, honestly, her long-term prognosis is not great, given all of her issues. So for here, this is all about harm reduction. I would much rather have her, you know, her sugar's a little high than have her passing out all the time, which is what was happening to her before, and same thing with the blood pressure. This couple has been together for over 65 years. They really love each other, and they are very, very religious and believe that God will protect them from poor sort of health outcomes, and their goal very clearly is to be together. So they do not want either of them to be in the hospital or in a nursing home because they would like to live out the remainder of their days together, and that's really their goal, and that's what I'm trying to facilitate for them. They're lovely. We tried to minimize the number of appointments that she has. I mean, you can imagine after all of these, like, you have to follow up with, hematology and pulmonary and GI and rheumatology, and like the list goes on and on and on. And like I said, at this point, only some of that stuff is really where she needs to be, and minimizing some of that allows them to be together more. And in the last year that she's been part of our program, we have made a lot of house calls, not only follow-ups, but also for urgent issues. She's had one ED visit after a fall to rule out a fracture and a bleed, so for a head CT, and one hospitalization at home when, unfortunately, in the last horrifying flu season, she developed flu and needed to be hydrated and supported through that. But it's still a big difference from where we were, before house calls for them. All right, so I'm wrapping up here. It's been really exciting to be part of the national conversation about this. And the longer I work here, the more I am getting used to just making things up that I believe in and trying to kind of go for them without tons of evidence behind them. But in the end, I do have to say, since this is a grand rounds, that what I'm about to say is pretty much my opinion. But it's not only my opinion, it's hopefully at least the opinion of many people around the country who work in this field. It's not that big of a world. We all kind of know each other, and we've tried to come up with what we consider best practices for those of you that are interested in this work and are thinking about starting your own programs so that you don't make the same mistakes that we've already made multiple times around the country. So I'm going to wrap up here with that list. Some of this I've mentioned already. Number one, risk is local. So don't read a paper about something that was built in like a rural area for young substance abusers and then think that you're going to be able to plop that model into East Harlem for like a frail elderly population and that's going to work. You really need to understand your own group that you're targeting and what's driving their risk, and try to pull from the literature then what might be similar to your own needs. Another big thing that we've found as people have been doing this around the country is that it tends to work better to leverage programs that already exist. So what do I mean by that? Work with practices that patients already trust and go to. It doesn't generally work that well to kind of hang up a shingle and be like, okay, high-risk patients, come here. These patients, their care is already very fragmented. There are often a lot of trust issues here. And so working it into their site of either primary care or specialty care, I mean, I know we're doing this, for example, in heart failure. It doesn't have to be in primary care, but somewhere that the patient already engages with and trusts tends to work better than like a totally new structure. All right, don't forget about my lessons learned. Don't assume that the data piece is going to be easy. You need to think about it. You need to test it. You need to kind of figure out what population you're really targeting. You're looking for the frequent flyers, you're looking for the high-cost patients, you're looking for frail. You need to have a sense of who you're looking for so that you can apply this to the right people. Ensure that your program is somewhat flexible so that as patients become less risky, they have a place to go. And as new patients develop high needs, you can accommodate them in your program. And I really don't think any of this work can be successful unless you think about what type of interdisciplinary team you're going to work with and include social determinants in your work. Make sure that anything you're using, any kind of assessment that you're using to bring patients into the program is not only medical, but really can get at what's actually driving their issues so that you can try to intervene on the true issues. In general, anything in person has much better data than telephonic, but obviously it's a lot more expensive, so there has to be some balance there. But telephonic models, though very popular, like in the payer world, in the insurance world, don't have great data behind them. You must figure out a way to engage the caregivers of your patients. I mean, you all know half the time the patients are not even calling 911. It's like their challenging daughter that's calling 911. So if you don't have a framework and a structure to engage the people that are caring for our patients, it's also very hard to move the needle on this. If you can, there is good evidence for having a home-based component in all of this. It doesn't have to be sort of all home-based, but if you have the flexibility to be able to do a house call when the patient needs it, there's pretty good evidence for that. Any of these programs have to be able to collaborate across specialties. You can't have a situation where like cardiology tells them one thing, you're telling them something else, and rheumatology tells them a third thing. You know, we need to take it upon ourselves to work together so that we're all moving in the same direction for these complex patients. And finally, don't forget about the overlay of these two areas, which time and time again, when we review these challenging medical cases, sort of boil down to one of these two areas. One is underlying behavioral health issues that are complicating the medical issues and making them impossible to control, or goals of care or end-of-life issues that mean that the chronic illness is really not going to improve, and you need to shift the conversation for the patient and family to understand what their goals are at this point in the illness. So I think any of these programs, there needs to be some overlay of both areas. So I'm done. I hope that this gave you some context for why this is getting so much attention and options for different models that we're using here at Sinai and around the country to engage these patients. We are always excited to work together. If any of you are interested, come find me and we'll put you to work. And again, I would encourage you to really think about how to innovate for your own patients and improve care for them. I really appreciate your time. Here's the end of summer and the first day of school. And I'm happy to take any questions that you have.
Well, first of all, congratulations on embracing such a difficult aspect of medicine. I don't know that we understand what old people and their adult relatives, their adult children feel about all of this. Maybe you do know, but it's like a mystery. The power base seems to be those who run the healthcare system, running hospitals and other organizations, and they have to save money. That's obvious. I'm not sure what old people and their adult children feel about all this. And I wonder if you have some insight into that.
Oh, sure. I can't speak for all old people, but I will say a few things. First of all, I'll say that I think the point you're raising is a very important one, in that whatever we build has to be driven by the patients and not by us thinking that we fully know what all patients want or need, which obviously is not the case. And we've learned a lot from talking to our own patients and trying to pull out of their feelings what we could do better. You know, I think the cost issue is clearly not the reason that any of us are interested in this work. It's the reason that this work is becoming more possible and more sustainable, and that there's political attention for it. But I think the real reason is that we do recognize that many older people and their children and families are not happy with the care that they're currently getting in our system. I mean, my patient might be a slightly extreme example, but bouncing in and out of the hospital 6 times in 6 months and spending your whole life in a rehab when you want to be home with your husband is not a great quality of life. So I think they are looking for improved care, less fragmented care, care that aligns with their goals. And as long as you have a framework to do that, hopefully this will be more acceptable and honestly will be better for the patients.
John?
Ania, thanks for a great summary of all this exciting work. I actually feel inspired hearing about this and hopeful for the future. Yeah. I was also delighted to see that you mentioned physician wellness in there, and so I feel obligated to make a comment. You know, I think the promise of team-based care, which seems to be at the heart of this, is sort of a natural win-win. There's a lot of hope that that is an area that can really improve clinician well-being, precisely because what you said, you know, a lot of the answer here is not medical. So, and typically a lot of those needs have fallen on the physician, and so being able to shift that, a lot of that administrative and clerical and social work-based work to a team has a lot of promise for improving clinician well-being. I'm just curious, since you've been talking about this nationally, and you did mention on your slide, is that really coming up in discussion? Is that kind of natural win-win potential here something that you're seeing more and more?
In terms of wellness?
Yeah, are you seeing wellness being
Yeah,
mentioned
I mean, I
as
think,
part of this?
as you know better than anyone, this is getting more attention now, but I would say maybe not as much as it should. I think that most of the national conversation about this is more about quality and cost. So how do we make the care better for these patients and also reduce the cost for these patients? I don't think there's been as much discussed or studied about how the physicians feel about their own care when they have more support behind them. You know, in a way it seems obvious, like all this work kind of seems obvious, but I could probably maybe in another 11 years come back and give a different grand rounds about why team-based care doesn't end up being as easy as you think it is. It's not like something that you can just flip a switch and people work perfectly together and everybody understands their roles. It's just not that simple. So I think maybe as we do it more and more, I hope there'll be more study to how it impacts our own practice. I don't think that's out there that much.
You have time for one more question, Mike?
So I appreciate the fact that you presented randomized controlled studies, because otherwise I'm not sure how we learn anything. I was also happy to hear that at least for the first 6 months, there is significant cost savings. I did not hear, however, what the death rate is between the patients in the two different groups, or the length of time that they live from the time they start, you know, either being in the treated group or not being in the treated group. And I will state that the one way of saving money that I am sure will work was put forth by Mr. Lamb when he was governor of Colorado. When you reach Medicare age, don't treat them anymore. That was his proposal. What he did when he became 65, I don't know.
He might have felt differently when he was 65, but yes, we're not proposing to kill people to save cost here. Part of all of these models, you do have to assure that you're still providing high quality care. And I do think that's important because to your point about how older people feel about this, I think the more you focus on the cost aspect of this, like patients are rightfully kind of wary about it. The goal of this is not to withhold care, it's to improve it.
Great. Let's thank Dr. Wajnberg for
Thank you.